thank you for not reading my biodata. Because I want to talk to you directly and not through my biodata. I am little perplexed as to what should I talk to you. Except for Shefali, who comes from medical background, probably everybody here, and Dr. Professor Anand Kumar, everybody else here might not belong to medical fraternity, and probably that is the purpose of this lecture series. You said that you should explore other avenues and going out of zone of comforts. So you will bear with me if I will not talk about anything about science, technology, but mostly talk about health. That's number one. Secondly, I was wondering that with this different kind of audience, what is common between you and me? What should I share with you? And I realized that common between you and me is you and me. We are all human beings, similar bodies, similar minds, similar aspirations, similar emotions. And so it is better that instead of sharing with you my knowledge, which is always borrowed, and we heard today that knowledge has half-life of 2 years, I should share with you what I have experienced and not what I have read. In effect, I propose to share with you my autobiography. Sevagram to Shodhagram. Sevagram, Mahatma Gandhi's Ashram, where I spent my childhood, and Shodhagram is a place where I live today and work in Gadchiroli. So it's an autobiographical journey, but that's the only thing I have with you to share. Everything else is borrowed, external. Also, let me caution you that though I am going to talk about something which pertains to me, but I am not the hero of this story. I am only going to narrate to you as to how things happened. Consider me as a narrator rather than hero of this story. As you would see, probably story may apply equally to you. And so my journey begins. Some of you might be able to recognize this place. This place is Mahatma Gandhi's Ashram, Bapu Kuti in Sevagram, Wardha. Nearly 70 years ago, my father, who at his time had won all the possible gold medals in the university, and so Mahatma Gandhi and Jamnalalji had invited him to join the first national college that they had started in Wardha. So instead of going for ICS, he joined their college. He fought in 1942 freedom movement, and when he was released and the freedom of India was on horizon, then government decided that we would like to send this young economist to the US so that when he comes back, he will be very useful for independent India. So he got his admission, PhD admission in the US. Travel documents were made, scholarship papers were made. A week before his scheduled departure, he went to see Mahatma Gandhi in his ashram to seek his blessings. Now I am describing to you what I have heard from my father. Gandhiji was sitting in this Bapugati on a bamboo mat, writing something. My father went in, bowed to him. Gandhiji knew him, so he asked him, "How do you come, Professor Bang?" So my father, who was 28 years old at that time, when Gandhiji asked him, how do you come? He told him that, Bapu, I have been released from prison and I am going to the US for studying economics further and came to seek your blessings before my departure. So Gandhiji looked at him for a few seconds and then uttered only one sentence. He said, इकोनॉमिक्स पढ़ना है तो अमेरिका के बजाय भारत के देहातों में जाओ. My father came out and tore away his admission papers and fellowship papers right outside this Bapu Koti, and within 1 month he started living in a village 3 miles from Sevagram Ashram, trying to live like a farmer and understand the true economics of village by living with his students of economics. Later on, I asked him that, Father, if you had gone to the US and then joined probably Finance Ministry or Planning Commission, you would have made a significant contribution. But instead, you chose a very different path right at that moment. So what was the magic of the old man? So my father told me that when Bapu asked me to go to the villages of India, if he was living in the Rashtrapati Bhavan or Viceroy Regal Lodge, I would have completely ignored what he said and proceeded to go to the US. But when he asked me to go to the villages of India, he himself was living in this village called Segaon, which he had named Sevagram, living in a hut made of 100 rupees capital, was sitting on a bamboo mat, so that bamboo mat became a throne of the Emperor of India. His words became mantra, and that was the magic of Mahatma. 40 years later, when Rani and I, we returned from the US after our public health training, the words of Mahatma were still echoing in our ears. Go to the villages of India. And so we decided to go to Gadchiroli, the place where I live and work now. Now, where is Gadchiroli? As you can see in the map, here is Gadchiroli, 200 kilometers from Nagpur, 1000 kilometers from Mumbai. The borderline state of the Maharashtra state, bordering with Andhra Pradesh on the south, Bastar on the east. The poorest district, farthest distance from state capital, and so in every sense it's a neglected district. About 70% land, the surface cover is covered by dense forest. Govt is the main tribe. About 40% population is Govt, and this Govt land extends from Gadchiroli then through Bastar up to the Koraput Kalahandi of Orissa. Farming is the main occupation, paddy cultivation, which keeps people busy for nearly 4 months in a year. Primitive farming, for rest of the 6 months or 8 months, they survive by collecting forest produce. Here is a Govt woman who has collected mahua flowers in her basket, which she would now dry up, then store and consume when there will be food scarcity. So people live based on primitive agriculture and forest produce. When we went there, transport was very primitive. Even the sick women, sick children had to be transported, and that too, if the floods allowed, they were transported in bullock cart. Outside every tribal village, under a mahua tree, you would find a number of such wooden deities, idols. Every deity has a name. Gad Devata, Marai Devata, Balki Dev. And each Dev or Devata specializes in curing one disease. So what does it mean? It really means that in the absence of medical care, people have developed their own psychological, traditional, cultural solutions, because nobody wants his kith and kin to die without having any consolation of medical care. So if there is no medical care, they have created their gods and goddesses to have satisfaction of medical care. Gadchiroli was a village of 10,000 population, still a Gram Panchayat, and the villagers very kindly gave us this godown. They said, you two doctors have come all the way, so we give you this godown to start working. So for initial several months, this godown was our office, our research center, our training center, and our house also. Then we took house on rent at the outskirts of the village. Within few months there were huge floods, and for 8 days our house was surrounded by water from all the sides. No drinking water supply, no food supply, no milk supply, no newspaper, no telephones, no electricity, of course. So that was the first glimpse of the life to be in Gadchiroli, and that's how our search for health and healthcare in the forest of Gadchiroli started. We literally named our organization Search, Society for Education, Action and Research in Community Health. This is where our organization's headquarters is based now, right inside dense forest, surrounded by tribal villages, is our headquarters. This colony, we call it Shodhagram, a village from where we try to search, explore how to provide health care to the villages of India. That is the mission. From this place, we work in the surrounding hundreds of villages. Gadchiroli altogether has got 160 villages. So our challenge is how to provide health and health care to not only villages of Gadchiroli but also to 6 lakh villages of India. That was the message, go to the villages of India. And so the exploration is not only local. Through local, we are trying to understand the national, the larger picture, macro picture, and develop solutions which hopefully will be applicable and useful on the larger scale. Now, we began with a disaster in the form that initially when I was seeing patient, and then I found a patient, 8-year-old girl, pale, jaundiced, abdomen belly swollen. A patient was sent to me with a suspicion of heart disease, rheumatic heart disease, because there were murmurs in the heart. I suspected it to be sickle cell disease, which had never been earlier reported from that area. We established a test and lo, it turned out to be sickle cell disease. So we conducted a district sample survey and found out that nearly 15% population had sickle gene, and there were about 6,000 sickle cell homozygous cases. I don't want to go in the more medical details here. But then Maharashtra government gave an award to me for this research. It was published in research journal. As a young researcher, you feel little elated, but then nothing happened. Government didn't do anything. Healthcare system didn't do anything for sickle cell disease. So we went back to the tribal village leaders and told them that, look, this disease has been found in you, but government is doing nothing, so you should bring some political pressure. So tribal leaders looked at us, stared at us for a few seconds, then they said, डॉक्टर कभी हमने आपको कहा था कि ये हमारी बीमारी है? ये तो आपके दिमाग की बीमारी है. We never told you that this is our health priority. You came and you asked for a drop of blood and we said that look, the young doctor couple has come all the way from the US, so why disappoint them? So we gave you a drop of blood. We have nothing to do with this is anymore. It is your problem, you solve it. What we realized was that there was something seriously wrong in our research method, which alienated the very people whose problem it was. But the people got alienated from that problem and they said it is your problem. What was happening? When I looked into my mind, subconsciously I was addressing the peer group academicians who were not in Gadchiroli, who were present in various conferences, various medical colleges. Through that research, I was really addressing the academic bodies. That was my mental audience. And so we made one decision for search. Hereafter, no research will be conducted for the research community. We must address the problems of the community we work with and not the research community we imagine we are part of that. After that, we took no research project or no research problems which was not a problem of the local people. So how do you come to know what are people's problems? So then first time we had that humility of going from village to village. Rani and I went, and then only time when people had time to talk to you was in the night. So we had to sit with them around the night fire and ask them, what are your health problems? What are your health priorities? What sort of hospital care do you need? And they said that we are afraid of hospitals. Reason A, there are big buildings. Secondly, these doctors and nurses put some white coats around them. So we asked them what is wrong with white coats, aprons. So they said, in the Govt tribe, we wrap dead bodies in white cloths. So doctors and nurses who are already dead, how can they save us? So we don't go to them. And then they confided to us that look, these doctors themselves think that they are gods in hospital. There is no God in the hospital. And if there is no God, how can there be saving? So we don't go to hospitals. Having understood their mindset, we designed hospital which was made up of huts, which did not look like a hospital but which looks like a tribal village. Deliberately, so that the tribal people should not feel alienated or scared of coming to this place. This is our hospital OPD, registration room. And then today in this hospital nearly 40,000 patients are treated every year. 500 major surgeries are performed here. And then thus hospital got accepted and tribal named hospital. Then in a meeting I asked, what should we name this hospital? So they said, Ma Danteshwari Davakhana. Danteshwari is Govt tribe's highest goddess. I was still fresh from the US, so I didn't like the name. Ma Danteshwari Davakhana. You can't even tell this name in Delhi and Mumbai. Your hospital's name is Ma Danteshwari Davakhana. So I said, let's think of some other name. So the tribal women stood up and said, look doctor, this hospital no longer belongs to Abhay Bang. It doesn't belong to Rani Bang. It now belongs to us and we have decided the name Ma Danteshwari Davakhana, and so it is. That hospital is named Ma Danteshwari Davakhana. And that's how the distance, the walls between tribal people and our imagined scientific priorities, those walls were removed and we started understanding what do tribal want. What do they need? So as a next step, we also constructed this temple of their Ma Danteshwari. तो आना है हॉस्पिटल में तो डॉक्टर का चेहरा देखने के पहले अपने देवी का चेहरा देख लो. So patients when they come, they first worship the goddess and then they come to the medical OPD. We started organizing how to get nearer to tribal people. So we started organizing in that Danteshwari Devi's name annual Jatra. And in annual Jatra, tribals came from all over and then we started organizing what we called Tribal Health Assembly. Representatives from nearly 50 tribal villages were selected by each village, and then they were sent to attend this assembly, in which issues were discussed as to what are the health problems on which we want solutions. In the first Tribal Health Assembly, through a ballot box, through voting, tribal people identified these 4 as their highest priority. Malaria, number 1, back pain, number 2, alcohol, number 3, and third they said, our children die. Do something for this. In the last 25 years, most of the work that we have done there is to try to address these 4 problems, the agenda, research agenda which was set for us by tribal people in the first Tribal Health Assembly, and I can't really claim that we have solved all the 4 problems. We are still exploring. I am going to share today with you only story of one of these problems, that is our children die. So we started measuring. Measurement of the problem and the analysis of the cause of the problem is half of the problem solving. And so we started measuring, established every birth and every death recording system. This is called vital statistics recording system. So in those 100 villages which became our population laboratory, when we first measured meticulously for the whole year, we estimated that the infant mortality rate was 121 in 1988. Now I must very briefly tell you what is infant mortality rate. In short, IMR. Now infant mortality rate has become a very important indicator of health services, of human development, also part of Human Development Index. What is it? If 1000 babies are born alive, within 1 year how many of them die? That is infant mortality rate. Here it means if 1000 babies were born alive in the villages of Gadchiroli, 121 died before their first birthday. Just for comparison, what is the IMR of Kerala today? 11. What is the IMR of the US? 6. What is the IMR of Japan? 4. And Gadchiroli had IMR of 121. Very high level of infant mortality rate. What were the causes? Why did children die? Now most of the children who died were never seen by any doctor, so there were no medical certificates. So we developed a method called verbal autopsy. That you visit after the person is already dead, maybe 15 days ago, 1 month ago, and through verbal inquiry, you eliminate other causes and establish the most probable cause. And this is what we found. That the child deaths, the largest number came from newborn deaths, first 1 month of life. Neonates are very vulnerable, 39%. Pneumonia in children, 20% deaths caused by pneumonia. 19% were caused by diarrhea. 7% were caused by malaria, and 15% were caused by diseases which could be prevented by immunization. Now out of this, we decided, and malnutrition was a predisposing cause for most of these. So we decided to focus on pneumonia and neonatal deaths. For diarrhea, by that time World Health Organization was proposing oral rehydration salt, simple solution for prevention of death. It was already known. Immunization program was going on. What was left out was pneumonia and neonatal mortality. So we chose this as something to be solved. Now, how do you save child dying of pneumonia? Now, I don't know whether you have seen children with pneumonia. This is a baby 8 months old, and you can see baby is miserable, gasping because it is breathless, and on the chest you can see deep depression. This means the child is so air hungry and the chest is not sucking air enough, so it is breathing with great effort, so the chest is getting sucked in. So this is a sure sign of pneumonia. Pneumonia is one of the main cause of death of children world over, more so in India. Why should children die of pneumonia? We have very effective antibiotics discovered nearly 50 years ago, Alexander Fleming, but those antibiotics never reach where these children are dying of pneumonia. So the main challenge was, who should diagnose pneumonia in the village where there is no doctor? If an ordinary villager suspects pneumonia, how should he be sure? Children are always coughing, so every cough cannot become pneumonia. So if you do not have stethoscope and if you do not have X-ray facilities in the village, how to diagnose pneumonia in children so that the child would get necessary antibiotic is a crucial question in preventing death from pneumonia. World Health Organization then came up based on a study in Papua New Guinea by a pediatrician called Frank Shan. It came up with this, that if a child has cough, count the breaths. If you don't have stetho and if you don't have X-ray, count the breaths. And if the baby of 0 to 2 month age has got breathing more than 60 per minute, it is most probably pneumonia. If a baby of 2 to 12 months age has got respiratory rate more than 50, most probably this is pneumonia. Very simple diagnostic tool. Using this, we decided to train ordinary villagers to diagnose pneumonia and treat. And so, we started working with Dai. Now, Dais were illiterate. So, the problem was, how do you teach Dai to be able to count up to 50 or 60, which she could not? She could not count more than 10 or 12. 12 because of the old dozen system, British system, so she knew up to 12. But she couldn't count up to 50 or 60. And so, to help her, I designed this simple equipment which in those days I called breath counter. What is it? Here is 1 minute sand timer taken out from a child's play, where there is a 1 minute measurement sand timer, and there are 2 rows. One row is for neonates and another row is for 2 months to 12 month baby. Now here there are 6 beads. The Dai was trained to count breathing and on completing 10, move 1 bead. Then she can't count beyond 12, but she doesn't have to. After 10, she again starts counting from 1, 2, 3, 4. Completing 10, move the second bead. Now she doesn't know what number it is. But before the sand has passed, if the red bead is moved, it is pneumonia. And if the baby is little elder, 2 to 12 months, she would select the second row and there more than 50. So there are 5 beads. Before the sand has passed, if the red bead is moved, it is pneumonia. We trained using this equipment, breath counter, a group of 50 Dais and then compared their diagnosis with my diagnosis using Littmann stethoscope. And in 82% of the cases, their diagnosis matched my diagnosis, so it was correct. So they became almost 82% doctors. And with that, we thought that that was enough at that level. And with that, here one Dai called Yashoda Bai from village Bodli is using breath counter. And then they started treating children with pneumonia using the antibiotic called cotrimoxazole, and look what happened. The first bar, this shows really the case fatality. Means if 100 children develop pneumonia, how many of them die? That is called percent case fatality. So before this treatment was introduced through community health workers and Dais, only treatment was available with the doctors at PSC or private doctor, which most of the parents never reached. So the death rate was 13.5%. With this treatment became available now, counting respiratory rate, diagnosing pneumonia and giving antibiotic, the death rate dropped to 0.8%. This was in 1988. This study was immediately published by the Lancet as the first controlled field trial which had successfully shown that the pneumonia mortality can be reduced in developing countries. And the case fatality of less than 1%, 0.8% that I am showing you here, was initial years, but now it's almost 25 years that we are continuing with this program. We meticulously count every pneumonia treatment and its outcome, and the case fatality is persistently less than 0.5%. I am very sure that even if I had treated all those children, I wouldn't have probably achieved such a low case fatality. And so, these ordinary looking women, community health workers or dais can take medical care, health care and all scientific miracles that we have discovered over the last 100 years but which never reach where they are needed. You train a person from the village itself and lo, miracle happens and these interventions start reaching where they ought to be reaching. Look, what is the irony? You and me, educated middle class, when we develop sore throat, whether it is viral, bacterial, without waiting, we start swallowing antibiotics. And children who are malnourished, who develop serious chest infection and pneumonia, issue of life and death, they don't receive antibiotics. So this simple solution of training a person from the illiterate or semi-literate person from the village to diagnose and treat pneumonia, subsequently Gadchiroli trial became part of the global pneumonia guidelines developed by WHO, and on these lines global guidelines were issued. There were other 4 trials also with, though not exactly same but similar kind of evidence, and ARI pneumonia control program became a global program. So we have solved out of that pie diagram, pneumonia problem was solved, but then the bigger problem was newborns. Now newborn is a period of from birth to 1 month of life. It is the riskiest period in the human being's entire lifetime. Within that 1 month, about 60 neonates used to die. 1,000 babies born, 60 died within 1 month. Another 60 died in the remaining 11 months. So this first month, 1 month was 11 times riskier than other 11 months. And newborns are fragile. They grow up as fetus inside the womb, but when they come out of the protection of mother's body, they face the very hostile environment, cold, warm, infection, hunger. And because traditionally very little is known about newborn care, science of newborn care never reached those villages. Where did these deliveries occur? In the huts. And even in the huts, the most dark and ill-ventilated room was selected as a delivery room, because for the next 2 months that room cannot be used for anything else. And cow delivered outside and women delivered in the adjacent room, as worse as cowshed inside, and they were not allowed to leave that room for next nearly 30 days. Now imagine if she cannot go out even for toilet, a pit was dug there in the room itself. Now it used to smell horribly. And to cut down the toilet needs, mother used to cut down her water intake and food intake. And in such horrendous situation, these newborns were cared for how many? 20 million neonates born in rural India every year. Medical care never reached there, and those babies were never taken out of those dark rooms because traditions didn't permit. Nazar lag jayegi. And so, this was the bigger challenge, how to save these neonates. World Health Organization had raised its hands. It is impossible, they said. Newborns are too fragile, too difficult to diagnose, too difficult to treat. Only solution is go to the hospital. But where were the hospitals? The Gadchiroli district, 300 kilometers long, there was only one district hospital where neonate could be some semblance of treatment could be provided. And these babies were not allowed to go out of that room. So the medical technology, newborn ICUs, NICUs as we call them, ventilators, incubators, they are all very good. But these babies never reached where the hospitals were, and hospitals never reached where the babies were. And nearly 12 lakh neonates died in India every year at that time. So with this challenge, we were perplexed, and thank God I am not a pediatrician. Because if I was a pediatrician, I couldn't have crossed the regular boundaries of pediatrics. Then you are bound by your science. Fortunately, I was not a pediatrician, so I could do anything with pediatrics. And so I said, the babies cannot reach hospital, nothing doing. Hospitals or medical science must reach where the babies are. And if doctors and neonatologists would not reach, then we must again make a village woman as a village neonatologist. Well, what doctors and neonatologists are not born from heaven at the birth with the medical knowledge. They are also born like any other human being. If they can be trained, why can't an ordinary village woman be trained? And with that, and the guiding principle was how far a mother on foot can walk with a sick baby in her arms. Healthcare must be available within that distance. This was the guiding principle of China's health policy set in 1951 by the first Chinese National Congress. And so they developed barefoot doctors. In India, we never allowed any doctor less than MBBS to treat anybody. And we doctors immediately go on strike if anybody else is trained or given power to treat patients. So we want our medical monopoly. Let the children die. And so, taking cue from there, we designed what we call home-based neonatal care. Not NICU-based neonatal care, not hospital-based neonatal care, but home-based neonatal care to reduce neonatal mortality by developing a low-cost, home-based model of primary neonatal care by using the human potential available in the village. And who was the human potential? She is Kajubai. Kajubai is from village called Ambe Shivni in Gadchiroli. 7th standard fail woman, Dalit woman, husband was alcoholic, later on died of tuberculosis, but Kajubai had enormous desire to do something for her village, a woman with significant leadership capability. We selected such 39 women from 39 villages, one from each, through a very rigorous process of selection. What mattered was not school education. What mattered was the attitude, temperament, empathetic, caring, willing to communicate, willing to wait in a hut for several hours patiently. These were the qualities we were looking for. And these were called Arogya Doot, messengers of health, and they were trained through a rigorous process, like a mini pediatrician. A 28 days training program in which they were trained to make home visits, ask mother about newborn health, weigh the baby, measure the temperature, do the thorough examination of newborn baby, and also make diagnosis. Now in the first year, we decided to do nothing because we did not know what to do. WHO did not know what to do at the village level. So we only observed. the natural history of neonates as it happens in an Indian village. In 39 villages, total 763 neonates were only observed and recorded all those variables. Based on this, we estimated that 48% neonates had serious illnesses, 72% had minor illnesses, 54% needed medical attention, but only 2.4% were seen by a doctor, only 0.4% were hospitalized. So very obviously doctors and hospital-based solution wasn't practical. So with this kind of morbidity load, we also analyzed why did they die. 40 neonates died in the first year. We had now by that time information record collected by Arogya Doot on each of these neonates. So we sent all those records to the All India Institute of Medical Sciences, New Delhi, and the professor of neonatology assigned there why did this baby die. And as you can see, nearly half of the deaths were because of sepsis, which is serious infection. 20% were asphyxia. When the baby was born, it was suffocated, did not breathe immediately. If baby doesn't breathe immediately within 5 to 10 minutes, it is dead. And then 15% died because of prematurity. They were born preterm, not mature enough to survive. And so we decided to focus on these three causes. If we could either prevent these three causes, or if we could not prevent, treat these causes and save the babies, we would have managed nearly 85% of neonatal deaths. Fair enough. We didn't have to bother about rare causes of congenital diseases and metabolic diseases. These were the three main killers of neonates. And with that, Arogya Doots now were trained to also diagnose and treat. So how do we prevent, diagnose and treat? Here, one Arogya Doot called Maya Bai from a village called Murza is using a flip chart, 36 pictures, to educate a woman during pregnancy as to what will happen to your neonates, how would you take care of your neonate, how would you breastfeed, how will you keep hygiene, which are the danger signs. If danger signs appear, immediately call me. So health education was the most powerful tool. Knowledge is the best vaccine. So in a way, she is vaccinating the mother against neonatal death. Preterm babies. Preterm babies are also very low birth weight. Sorry. Now, these are twin babies born with 1200 grams and 1300 grams. You can see very thin, skinny, and you can also see houseflies sitting. So there was an issue of keeping these babies warm, because in the winter they would become cold, hypothermic and die. There was issue of keeping them hygienic so that they wouldn't develop infection. And so in the absence of preterm units and incubator, we developed those simple bags, warm bags, in which such babies were kept at home itself. And the Arogya Doot made more frequent visits to assist mother in taking care of these babies. So preterm babies were taken care of like this. As we had seen, remember, half of the deaths were because of infection. It is very difficult to diagnose neonatal sepsis. Even doctors find it extremely difficult. But without going in the diagnostic difficulties, we developed a very simple clinical algorithm using which ordinary village Arogya Doot could be trained in 3 hours to make a diagnosis of newborn sepsis. And now I am going to make a statement which will startle you, but believe that it's a scientific statement. We have published evidence in international journal. The statement is that the diagnosis of neonatal sepsis done by our trained community health worker was equal to or better than the diagnosis of neonatal sepsis made by the neonatologist in Harvard. Without going in the details, look, in the America they make excessive diagnosis. And right and left they give antibiotics, so 95% of their diagnosis is false. They don't want to take any risk. So even at the slightest suspicion, they start antibiotic to neonates, while our diagnostic criteria were far more rigorous. And so the diagnosis in Gadchiroli was better than diagnosis in Boston. But how do you treat them? They need to be given antibiotic and injectable antibiotic. For pneumonia, we could only give oral Trimexol in bottle, but here we needed injection. Now, how to give neonate injection, and village woman is going to give that injection? So, fortunately for us, we found that gentamicin medicine, which is given for neonatal sepsis, comes into the strength of 40 milligram per ml, and the insulin syringe which is used for giving insulin injection also comes in the same strength, 40 units per ml. So as if it was God made for us, because insulin syringes came pre-sterilized. They have very thin needle, I hope, yes, they are very thin needle, so they are very useful in neonates without injuring anything in neonate body. Arogya Doodh could also very safely inject very precise and measured dose of gentamicin, 7 milligram, 8 milligram, 9 milligram, depending on the body weight. And so with this, we trained our community health workers to diagnose neonatal sepsis and treat. But then finally, we were in ethical dilemma. Never in the history of medicine and public health, village women, 5th and 7th past village women were trained as a neonatologist, and they were given authority to treat very sick neonates. So we invited 10 topmost pediatricians of India to Gadchiroli. The man with the turban is Dr. Meherban Singh, who was at that time chairman of pediatrics at the AIIMS, and whose textbook of neonatology every medical student follows. Another bald man, Professor Ramesh Poddar, was professor of pediatrics in Mumbai and at that time president of Asian Congress of Pediatrics. So this group of 10 senior-most pediatricians of India, we told them this is what we propose to do to save neonates of India, and before we really start this treatment in villages, please examine our workers, trained workers, also examine our intervention plan, and are we really on right path. For 3 days, these professors took examination and evaluated our community health worker more than what they would do for their MD candidates. And at the end of the 3 days, Professor Meherban Singh publicly said that these ordinary looking women, trained Arogya Doots of Gadchiroli, they know about newborn care more than the medical graduates of All India Institute of Medical Sciences. And that committee gave us ethical and technical clearance to go ahead with this intervention trial. And so these interventions were introduced in 39 villages. 47 villages acted as our control area, which were under government program. Kajubai here, same Kajubai is treating a neonate. This is the 5th day of treatment, so baby is now much better. She is injecting gentamicin to that baby. So the full home-based newborn care intervention started, delivered by those 39 trained women. Supervision, monitoring, quality control, record keeping, every record was computer entered. We monitored quality of this care on 36 specific indicators, quality indicators. In any village, if the quality indicator went down, the Arogya Doodh received retraining. And now look at the impact. Here, the various main causes of neonatal death and what was happening before and what happened after this home-based newborn care. So death rate in low birth weight babies dropped from 11% to 4.9%. Death rate amongst preterm babies dropped from 33% to 10%. Sepsis from 18% to nearly 7%. Asphyxia from 38% to 20%. Most of the major causes or major illnesses, diseases, case fatality dropped by 50 to 60%. And look at the impact on neonatal mortality rate. 1,000 babies born, how many die in first 1 month during newborn period? That is called neonatal mortality rate, NMR. Now, this is NMR in the control area. the government area. The baseline are very similar. This is the intervention 39 villages. Baselines are similar with a little difference. 62 in intervention area, 58 in control area. Other variables, education, caste, socio-economic, healthcare availability were all equally distributed in these two areas. In the control area, look at over the period of 10 years, except for this 1 year random fluctuation, throughout these 10 years the NMR has remained at 60 or above. And the control area represented India as a whole, government program area. And this really matches with the national data. Practically NMR was stationary for 10 years, which means we did not do anything for neonates of India for 10 years. In the intervention area from 62, by the end of the third year, the NMR dropped by 62% as compared to the control area. Subsequently, the research trial was over. We continued as service program only. By the end of the 7th year, NMR was 70% less than in the control area. Just for comparison's sake, let me tell you that if NMR reduces by any new medicine or new intervention by 5%, it becomes national headline in the US. And here, it had reduced by 60 to 70% within 3 years. Look at the effect on the infant mortality rate, which we talked earlier. Death rate up to the age of 1 year, because now newborn deaths and pneumonia deaths both are being treated. So when we began 1988, the IMR was 121. We introduced pneumonia program that you saw earlier. With that, the IMR, ignore those random fluctuations because area is only 39 villages, so you do get random fluctuations. So IMR reduced to nearly 80. And then home-based newborn care introduced. IMR reduced and reduced and reduced and reduced and finally became stationary at the level of 30. From 121 to 30, when World Health Organization was saying that nothing could be done. And then, mere coincidence, but later on, Government of India chose IMR of 30 as the national goal for India. And these villages, 39 villages in Gadchiroli, had already achieved that goal. When the India's IMR was 72, it had reached 30 in those 39 villages. Poverty remained same, illiteracy remained same, remoteness of Gadchiroli remained same. What happened? What happened was that only few village women were empowered. And these are the 4 pillars of home-based newborn care who made this miracle possible. This is mother, this is grandmother, and look on their lap you can see twin babies who were very low birth rate. And this is Dai, old traditional woman, and this is the new Aragyu whom we introduced newly with training. Now these 4 women, they really performed this miracle. Abhay Bang was not present in every village. They did this miracle. And look at them very carefully. You will find what is special about them. Observe. Thing very special about them is that there is nothing special about them. They are as ordinary as any woman in any village in India, and you would find hundreds and hundreds of such women in every village in India. Why only India? In Pakistan, in Bangladesh, in Nepal, in Africa, in Latin America, world over, village after village, you will find such ordinary women waiting. Please give us a little knowledge and give us a little power, and we will save our children ourselves. Home-based newborn care makes that possible, that they can really do it. And what do they have? What do they need? It is same Kajubai now, photographed 20 years later. Now look, these are the set of equipments that she has for home-based newborn care. Let's not go in the details of equipments, but simple, all these equipments together cost 1500 rupees. 1500 rupees of equipments, 28 days of training and supervision, and All these equipment she can carry on this shoulder bag, home-based newborn care kit. And now with this kit on her shoulder, and with knowledge in her head, and skills in her hands, and compassion in her heart, she literally is a mobile newborn care hospital. And now when I am talking on scientific issue, I do not exaggerate. When I said that she is equal to a mobile newborn care hospital, we have published in the American Journal of Perinatology comparison of death rate. Babies of the same gestation, same birth weight, treated in the 13 hospitals of India and treated by Arogya Doots and Gadchiroli, and the death rates are similar. So the quality of care that the Arogya Doots provide to these neonates is equal to, at least equal to, a secondary middle level hospitals in India. And that's why we call this home-based newborn care an empowering model. This is the logo of home-based newborn care. Look, that hut was dark. That woman was alone, helpless, with a baby at her bosom. How do I save my baby? And open this one window of knowledge, window of opportunity, and village women become empowered, and they can lift the entire health of the village on their empowered hands. So what we need is empowerment model, not dependency model. This empowerment model we call Arogya Swaraj, where village can take care of its own health, where village doesn't need government, where village doesn't need hospital, where village doesn't need doctors, because they can't depend on any of these. Availability is not ensured. And so this is a picture of Arogya Swaraj. This study was again published in the Lancet as the world's first study of how to reduce neonatal mortality in communities in developing countries. And nearly 10 years later, the Lancet editorial team and the historian of Lancet, they decided to select the best papers ever published in the 180 years history of Lancet. Major medical milestones like Ronald Ross discovering malaria transmission through mosquito, or Robert Koch discovering cholera bacteria or tuberculosis bacteria, or Benting and Best discovering insulin and Alexander Fleming discovering penicillin. They were all included in this vintage paper from Lancet volume. And when you came to 1990s, you have there a paper from a remote unknown place called Gadchiroli, home-based newborn care, as one of the best papers published in 180 years of medical history. Now the next challenge is, ठीक है, गढ़चिरोली में हुआ, आप खुद थे वहाँ पे, तो कर दिया आपने miracle. Can it be done elsewhere? The problem is not limited to Gadchiroli. So only showing something works in Gadchiroli is not enough. And so we conducted a series of field trials. First, a 7-site field trial in Maharashtra at 7 different districts. Repeated the same pattern. Then Indian Council of Medical Research repeated the home-based newborn care in 5 states. Everywhere using the same package as we had used in Gadchiroli, and everywhere it was possible to provide home-based newborn care, and the mortality significantly declined. And so we developed now the methods how to train others, how to train the trainers, how to train the supervisors, and how to train community health workers elsewhere. So now we have training system ready. Government of India then incorporated 11th 5-year plan, 12th 5-year plan, both incorporated home-based newborn care as the mainstay of India's strategy to reduce child mortality. NRHM in 2011 brought out national guidelines on how to implement home-based newborn care, and a great thing happened. ASHA, a community health worker, was deployed in every village in India. And one of the major influence, not the sole influence, but one of the major influence was Gadchiroli trial, that village women can be trained to do all this. So now currently there are 8 lakh ASHAs in India who are being trained. Apart from several other things, they are also being trained to provide home-based newborn care. So the training system was developed in search in the Shodhagram headquarters that you saw, and then module 6 and 7 were prepared. TOTs were conducted in search for all national and state trainers. 300 state trainers were trained. Then they went and trained 5,000 district trainers, and these 5,000 district trainers are today training 8 lakh ASHA in India so that home-based newborn care can reach every neonate. 20 million neonates in rural areas born every year. So what is local? From Gadchiroli, it became national. These are the various states where home-based newborn care has been introduced. In almost all states except Tamil Nadu and Kerala, where anyway they don't need home-based newborn care because their IMR is very low, so they don't need home-based newborn care. In all other states it has been introduced, not only here, but you can see it is introduced now in Bangladesh, in Nepal, in Pakistan, in 4 countries of Africa. In Ethiopia it has become a national program, and it is now introduced in Bolivia also. Knowledge is such a powerful lever. You don't have to go anywhere. Knowledge is such a powerful lever. Remember when Archimedes boasted that give me a lever long enough and a place to stand outside earth, I can move the earth. Everybody of course laughed in those days, but we know now that he was correct. By the principle of lever, he was correct. Knowledge is such a lever that sitting in Gadchiroli, outside government system, with our weak arms, very weak. We have no money, no great institutional backing, no national institutes. We are a small NGO, a fringe NGO. And those 39 community health workers, even weaker than us. But with our weak arms, but with the power of science and evidence in our hands, global policies have changed. WHO and UNICEF and USAID and Save the Children in 2009 brought out a joint declaration that home-based newborn care is the preferred method of providing care where hospital care is not accessible. So, problem, yes, everywhere problems are there. But then start with measurement, start with developing simple solutions, technological solutions, test them repeatedly, involve people in delivering them, and the most crucial, the solution should not be disempowering people, they should be empowering the people. So these Arogya Doots, when the 10 years of home-based newborn care were completed, we gave each one of them a bicycle as a gift. Look, they had really done a miracle. Based on what they did and what they performed, national and global policies were shaped. And they are so eager to move out of Shodhagram and spread this message everywhere in the world. Now the challenge of child deaths in India, 16 lakh, this is little old slide, now 13 lakh children die every year in India. And at least half of them, these deaths could be prevented by using the method developed in Gadchiroli. This photograph, I don't know if you recognize, it's old photograph taken nearly 2 decades ago. In the severe famine in Ethiopia, an American photographer took this photo. Child, terribly starved, malnourished, almost waiting to die. That child is so tired, it has stopped all its struggle to survive, and a vulture is waiting there. This photograph received global recognition and global awards as the most pithy commentary on the helplessness of children and famine in Ethiopia. But within 6 months, that photographer committed suicide. Why? Because he could not save that child. He knew that he took photograph He got fame and recognition, but the child died and must have been eaten by the vultures. That depressed him so much that he committed suicide. So friends, if our coronary arteries are open and if our hearts have not become stony hearts, every child which dies in India should hurt us. And if that hurting means that the sensitive people commit suicide, if they cannot save them, it means this issue of saving children is not only issue of saving children, it is the issue of saving myself. I am responsible for everything that happens in this world when I am alive. Jean-Paul Sartre during Second World War said, I am responsible even for the wars of my time because I was alive on the earth at that time. I am responsible for everything. So we are responsible for every child death which is occurring globally. And then so the question is, how do I save myself? The reality is so grim, it is so depressing that unless I do something, forget about that child. Even I get depressed and I have to commit suicide. If not real suicide, at least spiritual suicide. Several years ago, I was in London for a conference. That conference was जरा ऊंचे लोगों की थी. So they took us first to meet Queen Elizabeth in the Royal Palace, Buckingham Palace. Then they took us to the British Parliament. Then in the House of Lords, we were felicitated. I was very uncomfortable. This is not your everyday experience. So I was very uncomfortable with that very high profile delegation. So when we came out of British Parliament, right in front of British Parliament there is a square. And you have all seen that photograph of that square because Mahatma Gandhi's statue was just 2 years ago unveiled there by, I think, Mr. Jaitley had gone there. So but there was no statue at that time. And there were some stray people protesting in that square. So I felt more closeness with them. So I left this delegation and went with them. So there was one group, each one had their placards. There was one group which was protesting against Iraq war and they were saying, bring back the British troops from Iraq. These were the pacifists, Shantatavadi. There was another group which was saying that sign Kyoto Protocol. Tony Blair signed the Kyoto Protocol, environmentalist. And there were a third group who were labor unions representatives and they were saying that Tony Blair bring in pro-poor economic policies. Independent, three groups, nothing to do with each other. They had their different tents, different placards, different groups protesting right in front of British Parliament. But there was one common banner right behind them, a huge banner. It said, be the change yourself that you wish to see in the world. Mahatma Gandhi. The different kinds of protest groups, the various political streams, the various action groups, everybody in the world today finds that their Mahatma was same as our Mahatma. And they use his quotations, his statements to increase their morale. I felt as if 60 years after India had won independence and Mahatma had died, still this Mahatma was standing there and challenging British power. So if I want to save those children, and children are just an example, I have built the whole story only around child death because one example needs so much time. So if I take several challenges, but then you can apply the same principle, same logic to every other problem of your choice. But only thing, ask first people what problem solution they want. Otherwise you will repeat the sickle cell story. And so, if I want to save them and as well as myself, because I am organically woven with them, I cannot survive if they die. If you go to the forest, in any reserve forest, and watch there for a time, you may find, if you are fortunate, you will see a very important scene. A herd of sambars which are grazing. When one of them notices that a tiger is lurking somewhere nearby, what should that sambar do? Now that sambar is the first to realize that there is a danger of the tiger. Now it has the advantage over other sambars. Other sambars do not know that tiger is lurking. So if it runs away, it has the advantage, it will be saved. But that sambar doesn't do this. Very surprisingly, the sambar doesn't follow the selfish law of save yourself. That sambar gives an alarm call. And that alarm call wakes up the entire herd and the whole herd starts running. In that process, the sambar endangers itself. Because now, tiger attention is focused, is attracted towards the sambar which has made the noise. Why should sambar do this? Was the sambar trained by Mother Teresa? वो क्यों परोपकार करता है? और सांबर जानवर, लेकिन वो भी परोपकार करता है. Because save the group, save the species, that is written on our genes. We are all biologically programmed to try to save the animals of our own species. So we are not doing any great mercy by trying to save those children or tribal or anybody else. We are programmed to do that. If we are human beings, we are programmed to save other human beings. That is your destiny. You can't escape from that. So spiritually, morally, as well as biologically, our duty is to help one who needs it. Our duty is to save one who is dying, and that is possible to do with the help of science, technology, inquiring minds, and a bent of solution development. Now question is, who would do this? And so 10 years ago, we started inviting youth from all over Maharashtra. We call this initiative Nirman. We invite youth from all over Maharashtra that come and explore. Explore what? Explore how do people live and what do they need, but also explore what is the purpose of your life. In search of meaningful life. A moneyful life is not necessarily meaningful life. So discover meaning to life beyond money. Every year, nearly 200 selected youth, we have rigorous process of selection like you have in IITs. So we select those whom we think are appropriate for this educational process. They are selected, they are exposed to the various social problems in villages, in tribal areas. They are presented with various people who have solved the national or large social problems, the role models and the icons, and then they are allowed, they are helped to explore their own path as to what do I want in life, what is the meaning of my life, where will I find fulfillment, what are my real economic requirements. Everybody of us is thinking, oh, economic insecurity aa jayegi, but you, if you really pen down, how much do you need for surviving? The fear goes away because you need that. You don't need much for surviving. Of course, if you have unlimited needs, then the earth is not enough for you. The old man has said, there is enough on this earth for everybody's need, but not even for one man's greed. So whether you want to go by need or greed, decide for yourself. And the price that you have to pay if you go for greed, the price has to be paid with your own life. You have to sell yourself for earning that money. All of us are Harishchandra. who have to sell ourselves in that slave market, in the labor market called job market. We stand there with our CV और मेरी कीमत लगाओ, और जो सबसे ज़्यादा बोली लगाता है उसको हम बिक जाते हैं. लेकिन उसमें कौन मर जाता है? मेरे भीतर कुछ मर जाता है. So we are helping, or I shouldn't use the word helping, but we are offering them a process of self-exploration, exploring the society and exploring the self, and where do these two meet, where do these two unite. I am here since yesterday evening and I have had opportunity to share here what you are doing in IIT BHU. I am very encouraged by several of your directors' initiatives and also your Kashi Utkarsh. And some of the youth have offered, some of the young people I met today, they have expressed desire that they want to come for Nirman. Wonderful. Because problems are not only in Maharashtra and the youth is not only in Maharashtra, it's in Banaras also. And so, friends, the exploration of the path never ceases. This story, which may appear autobiographical, is not autobiographical, because at the core level, you and me are very same. What moves me moves you also. So this could become everybody's story. Woods are lovely, dark and deep, but we have promises to keep. Robert Frost's famous lines. We have promises to keep and miles to go before we sleep. Miles to go before we sleep. And incidentally, this is Search logo. Thank you.